The year was 1962. Across the United States, hospitals were quietly turning away patients who could not pay. Not criminals, not strangers. Elderly men and women who had worked their entire lives, raised families, paid taxes, and built communities, turned away at the door because no insurance company would cover them anymore. Private insurers had made a calculated decision. Older Americans got sick more often. They stayed sick longer. They cost more to treat. And so, one by one, insurance companies stopped covering them, raised premiums beyond any retiree's reach, or simply refused to renew policies when people needed them most. The market had written off an entire generation. By 1962, approximately 30% of elderly Americans had no health insurance whatsoever. In states like Mississippi, Alabama, and Arkansas, that number climbed even higher. A single hospitalization, a stroke, a broken hip, a diagnosis of cancer, could obliterate a lifetime of savings in weeks. Families were forced to choose between caring for aging parents and feeding their own children. There were no federal standards for nursing homes. There was no minimum staffing requirement. There was no safety inspection protocol that carried real teeth. A Senate investigation launched in 1961 found that fewer than 60% of the nation's nursing homes met even basic health and safety standards. Residents lived in facilities where a single aide might be responsible for dozens of patients through an overnight shift. This was the America that existed before Medicaid. And here is the question that hangs over everything that comes next. 60 years after the government promised to fix that system, what happens when it starts dismantling the fix? Lyndon Johnson signed Medicaid into law in 1965. On the morning of July 30th, 1965, President Lyndon B. Johnson boarded Air Force One in Washington, D.C., and flew to Independence, Missouri. He was not signing the bill in Washington. He was making a statement. He was going to the Harry S. Truman Presidential Library. Because Truman had tried to do this exact thing 20 years earlier, and Congress had stopped him cold. The American Medical Association had spent millions of dollars in the 1940s calling Truman's national health insurance proposal socialized medicine. They called it part of the Moscow Party line. They ran one of the most aggressive lobbying campaigns in American history, and they won. Truman's proposal died in committee, and elderly Americans continued to face illness without a safety net. Now, 2 decades later, Johnson had the votes. His landslide victory in 1964 had handed Democrats a 2-to-1 majority in the House and 32 additional Senate seats. The political window was open, and Johnson moved fast. At the Truman Library, standing beside the 81-year-old former president, Johnson signed the Social Security Amendments of 1965 into law. He then handed the first 2 Medicare insurance cards to Harry Truman and his wife, Bess. Truman called it a profound personal experience. The legislation created 2 programs simultaneously. Medicare provided health insurance for Americans 65 and older, funded federally. Medicaid provided health coverage for low-income Americans of all ages, funded jointly by the federal government and the states. The first-year budget for both programs combined was approximately $2.2 billion. Within the first 6 months, more than 2.5 million Americans received hospital care covered by Medicare alone. What Johnson signed that day in Independence, Missouri was not just a law, it was a promise, a federal guarantee that no American would be left to face illness and old age without a floor beneath them. Medicaid became the primary payer for nursing home care. When Medicaid was created in 1965, policymakers assumed it would primarily serve low-income families with children. What happened instead reshaped the entire architecture of American long-term care in ways nobody fully anticipated. Within the first decade, Medicaid became the dominant payer for nursing home care across the United States. The reason was straightforward and unavoidable. Medicare, the program explicitly designed for the elderly, covered only short-term skilled nursing care, up to 100 days following a qualifying hospital stay. It did not cover custodial care. It did not cover the long-term assistance that most elderly Americans eventually needed, and private long-term care insurance was expensive, complex, and out of reach for most working-class retirees. That left Medicaid. And Medicaid's rules for nursing home eligibility required something that remains true today. Applicants had to spend down nearly all of their personal assets before qualifying. The asset limit in most states was set at $2,000. An elderly person with modest savings could qualify only after those savings were essentially gone. This created the pattern that now defines long-term care in America. A senior enters a nursing home, pays privately as long as possible, exhausts their savings, and then transitions to Medicaid coverage. Today, Medicaid is the primary payer for 63% of all nursing facility residents in the United States. It covers at least 44% of all institutional long-term care costs nationwide and 69% of all home-based care costs. In 2025, there were approximately 1.2 million people living in nursing facilities across the country. More than 750,000 of them had Medicaid as their primary payer. These are not wealthy people with options. These are Americans who spent everything they had before the system stepped in. Before we continue, don't forget to subscribe to the channel so you don't miss our upcoming updates on the situation in the United States. Thank you for your support, and let's continue. The program grew to cover 71 million Americans. The Medicaid that Lyndon Johnson signed into law in 1965 was a modest program by any measure. It covered specific categories of low-income Americans, primarily welfare recipients, elderly people in nursing homes, and families with dependent children. The first-year budget was folded into a combined $2.2 billion appropriation alongside Medicare. Most states were cautious about their initial commitments. What followed was 6 decades of gradual, often contentious, but ultimately dramatic expansion. In 1972, Congress extended coverage to people with disabilities and those with end-stage renal disease. In 1987, coverage expanded to pregnant women and children above the poverty line. The 1990s brought additional expansions for children. The Affordable Care Act of 2010 allowed states to extend Medicaid to all adults with incomes below 138% of the federal poverty level, and 40 states plus Washington, D.C. eventually did so. By 2025, Medicaid had grown into the largest health insurance program in the United States by enrollment. Preliminary data from March of 2025 estimated that 71.3 million people were enrolled. The program covered 1 in 5 Americans, 40% of all children, 60% of all nursing home residents, and over 5 million people receiving home and community-based care services. More than 12 million Americans were enrolled in both Medicare and Medicaid simultaneously. The combined federal and state spending on Medicaid in 2021 alone reached $466 billion. Federal funding alone accounted for 50% or more of each state's program costs, with the share rising higher for lower-income states. In states like Mississippi and New Mexico, the federal government funded over 70% of total Medicaid costs. The program had become not a supplement to American health care, but its structural foundation. Medicaid paid 63% of all nursing home costs. 4 in 10 Americans believe Medicare is the primary source of insurance coverage for people in nursing homes. That belief is wrong, and that misunderstanding has enormous consequences for what is happening right now. Medicare covers short-term skilled nursing care, a maximum of 100 days following a qualifying hospital stay, and only for care classified as rehabilitative rather than custodial. The moment a nursing home resident's condition stabilizes and their care becomes maintenance rather than recovery, Medicare stops paying. For the vast majority of Americans who need long-term nursing home care, that transition happens quickly. What takes over is Medicaid. And what Medicaid pays for is staggering in scale. In 2025, Medicaid was the primary payer for 63% of the 1.2 million people living in nursing facilities across the country. Medicare covered 14%. The remaining 23% paid out of pocket or through private insurance, and most of those people eventually spent down their assets and transitioned to Medicaid as well. The cost of nursing home care in 2025 exceeded $110,000 per year at the national median. Home care, the preferred and less expensive alternative, exceeded $75,000 per year. Over half of all Americans will need some form of long-term services and supports at some point in their lives, and the vast majority of them have no mechanism to pay for it other than Medicaid. In 2021, Medicaid accounted for 44.3% of all long-term services and supports payments in the country, totaling $207 billion. States depended on that federal partnership to keep nursing homes staffed, to keep home care programs running, and to keep their long-term care systems from collapsing entirely. That partnership is now being fundamentally restructured. 41 states already had home care waiting lists before any new legislation was signed, before any budget was cut, before the summer of 2025 arrived. 41 of the 50 states in America already had waiting lists for Medicaid home and community-based care services. That fact alone tells a story that Washington rarely discusses. The system was already failing millions of Americans who needed care at home. The least expensive option, the most humane option, the option that most elderly Americans overwhelmingly preferred. And those states could not keep up with demand even before the cuts arrived. The Kaiser Family Foundation survey conducted between April and July of 2025, completed before the new law was signed, documented the scope of the backlog. Across 41 states, people on those waiting lists waited an average of 32 months before accessing services. That is nearly 3 years. For people with physical disabilities and older adults, the average wait was 15 months. For people with autism, it stretched to 63 months. Over 5 million Americans were receiving Medicaid home care services annually, but the number of people who needed those services and were not receiving them was significantly higher. Home and community-based services are optional under federal Medicaid law, unlike nursing home care, which states are required to provide. That means when states face budget pressure, home care is among the first things cut. During the Great Recession of 2008 through 2010, every single state in the country reduced home care spending. Every state. Some served fewer people. Others cut benefits or reduced payment rates to providers. The pattern is documented, consistent, and predictable. Now states face budget pressure on a scale that dwarfs anything the Great Recession produced. And 41 states were already turning people away before the first dollar of the new cuts took effect. Congress passed the One Big Beautiful Bill on July 4th. The vote in the United States Senate came down to a single tiebreaker. On July 1, 2025, the Senate passed the Budget Reconciliation Bill by a vote of 51 to 50, with Vice President J.D. Vance casting the deciding vote. 2 days later, the House passed the same legislation 218 to 214. On July 4, 2025, Independence Day, President Donald Trump signed it into law. The legislation was formally titled the One Big Beautiful Bill Act, designated Public Law 1-19-21. At 940 pages, it was one of the longest and most sweeping pieces of domestic legislation in recent American history. It extended tax cuts first enacted in 2017, funded border security expansion, restructured student loan programs, and reorganized dozens of federal spending priorities. To pay for those priorities, it made unprecedented cuts to the American social safety net. The law included the largest reduction in federal Medicaid funding in the program's 60-year history, the largest cuts to the Supplemental Nutrition Assistance Program since its expansion in the 1970s, and a series of changes to Medicare eligibility and benefit access that advocates said would push millions of low-income seniors into financial crisis. The Congressional Budget Office, the nonpartisan agency that scores legislation for its fiscal impact, projected that the healthcare provisions of the law would result in 11.8 million people losing health coverage by 2034. When combined with related policy changes, that number climbed to 16.9 million. The law's sponsors argued it eliminated waste, reduced dependency, and returned fiscal responsibility to federal programs. Critics at Johns Hopkins, Harvard Medical School, and the American Medical Association called it the biggest rollback of federal health care support in American history. The debate over those competing claims was still underway when the cuts began taking effect. The law cut $911 billion from Medicaid. $911 billion over 10 years. That is the number the Congressional Budget Office assigned to the Medicaid cuts embedded in the One Big Beautiful Bill Act of 2025. It represents roughly a 14% reduction in projected federal Medicaid spending over the decade, the largest single reduction in the program's history since Lyndon Johnson signed it into existence in 1965. The cuts operated through multiple mechanisms simultaneously, each one compounding the others. Work requirements were the largest single driver, projected to reduce federal Medicaid spending by $326 billion alone. Adults between 19 and 64 enrolled through the ACA Medicaid expansion were required to document 80 hours per month of work, training, or community service, or lose their coverage. The CBO estimated that 5.2 million people would lose Medicaid under this requirement. Analysis by the Kaiser Family Foundation found that fewer than half of adults between 50 and 64 would meet the work requirements through employment or school enrollment. More than half of that age group reported a health barrier to employment. Provider taxes, the mechanism states used to generate the revenue needed to draw down federal Medicaid matching funds, were frozen immediately and then gradually reduced from a maximum of 6% to 3.5% by 2032 for expansion states. Every state except Alaska had at least one provider tax in place. For many states, particularly those with Medicaid expansion, those taxes were essential to maintaining current levels of care. The retroactive coverage window for nursing home applicants was reduced from 90 days to 60 days. The home equity limit for nursing home Medicaid eligibility was capped at $1 million, fixed without inflation adjustment, effective 2028. For a program that had spent 60 years expanding access, the architecture of contraction was now fully in place. 13,000 nursing home deaths expected annually from understaffing. In May of 2024, the Biden administration finalized the first ever federal minimum staffing standards for the nation's 15,000 nursing homes. The rule required a registered nurse to be on site at all times, 24 hours a day, 7 days a week. It required a minimum of 3.48 hours of direct nursing care per resident per day. The Centers for Medicare and Medicaid Services called these minimums essential to providing residents with safe, high-quality care while being treated with dignity. Researchers at the University of Pennsylvania analyzed what those standards could prevent. Their conclusion was precise and devastating. Implementing the rule could save approximately 13,000 lives per year. The rule never fully took effect. In April of 2025, a federal judge in Texas struck down key provisions of the staffing mandate, ruling it exceeded the agency's congressional authority. The Trump administration declined to appeal. Then, on July 4, 2025, the One Big Beautiful Bill Act imposed a 10-year moratorium on implementation, meaning no federal minimum staffing standards for nursing homes until at least 2034. On December 2, 2025, the Department of Health and Human Services formally rescinded the rule entirely. Chronic understaffing in nursing facilities was already well documented before any of this occurred. In 2023, American nursing homes received 94,499 health citations from federal inspectors. Nearly 8% of those citations, 7,654 in total, involved abuse, neglect, or exploitation of residents. 27% of all nursing facilities received serious deficiency citations for actual harm or jeopardy posed to residents. With the staffing rule gone and Medicaid funding shrinking, nursing home operators face less federal oversight and less revenue simultaneously. The 13,000 figure was a projection of lives that could be saved. It is now a projection of lives that will not be. 15 million Americans projected to lose health coverage by 2034. The Congressional Budget Office does not editorialize. It counts. And what it counted, after analyzing the full scope of the One Big Beautiful Bill Act of 2025, was this: 11.8 million Americans would lose health insurance coverage by 2034 as a direct result of the law's provisions. When combined with related policy changes, including the expiration of enhanced ACA premium tax credits and a separate CMS marketplace rule, the total reached 16.9 million people without coverage. For elderly Americans, the impact is layered, cumulative, and arriving on multiple fronts at once. The 22 million Americans aged 50 and older who currently rely on Medicaid face reduced services, higher administrative hurdles, and in many cases the loss of coverage entirely. The 13 million Americans enrolled in both Medicare and Medicaid simultaneously face a double impact. Medicaid cuts, reducing their assistance with daily living costs, while Medicare itself becomes more expensive and harder to access. The Center for American Progress calculated that a low-income older couple with a combined annual income of $21,000 could face up to $8,340 in additional out-of-pocket healthcare costs per year as a result of the law's changes. 8 million seniors who rely on the Supplemental Nutrition Assistance Program face reduced food benefits. The new law eliminated $186 billion in federal SNAP funding through 2034, a 20% reduction, while expanding work requirements to adults up to age 64. More than 300 rural hospitals are at immediate risk of closure as Medicaid revenue declines. Many of those hospitals serve communities where seniors represent a disproportionate share of the patient population and where the next nearest hospital may be an hour or more away. Lyndon Johnson stood in Independence, Missouri in 1965 and promised that older Americans would no longer have to fear that illness would wipe out their savings, eat up their income, and destroy lifelong hope of dignity and independence. 60 years later, that promise is being unmade, piece by piece, billion by billion, one waiting list at a time.